Many healthcare delivery organizations are using their experience in Medicare Advantage to leverage direct contracts between employers and their employees and themselves in terms of providing health care. And these types of relationships are absolutely fraught with danger, but they also provide exciting opportunities for development of care delivery systems and financial compensation. When I take a look at these relationships, I look at three things that are enormous red flags that the organization is putting their finances at risk in order to close these contracts. And the first is when the contract is negotiated before the care systems are in place. So the negotiators between the healthcare delivery organization and the employers determine what needs to be done, and then they sign the contract, but then the systems to deliver that are not in place. That is an enormous red flag because there's usually significant cost and extensive time before the workflows necessary to meet those contract metrics are in place, and a lot of times the financial penalties for not meeting those metrics are in place immediately. So that is the first red flag that I noticed. The second red flag is that these healthcare systems don't pilot these metric-based healthcare delivery systems on a very small scale before generalizing them to large contracts. It actually is not that difficult to select a group of patients or a population of patients and pilot looking at the specific metrics that you know that the large organizations are interested in. And then you can troubleshoot those through that pilot project, and then you can introduce that into these negotiations with large providers. And the third one, and this is the biggest red flag, is when these contracts are negotiated without a primary care clinician at the table. It's very rare to have a PCP at the table during these negotiations, even though the metrics rise and fall on the performance of the primary care group that works for the healthcare delivery organization. It's cardiologists, orthopedists, all these specialists and subspecialists are at the table, but the primary care doctor isn't. And as a result, these contracts can underperform to an incredible degree. So when you're looking at making these contracts, what you want to make sure is, one, is that you pilot any kind of specific metrics that are needed. Two, you make sure that you do start on a small scale before you grab that big contract with an enormous amount of financial risk. And three, you make absolutely sure your primary care clinicians are at the table. Without doing those three things, you might as well not get the contract because you will not be satisfied with the financial performance.